Good evening, ladies and gentlemen. It's my honor to be with you today, and I would like to thank every one of you, whether you are joining us from Oman, Saudi Arabia, Kuwait, Qatar, or United Arab Emirates. You are welcomed. I'm really thankful that you took time out of your evening to join this webinars. And the first webinar of DES webinar will be about the optimization of continuous glucose monitoring system. I wish that you will find this webinar tonight beneficial. We will start our first talk by Dr. Khadija Hafid. She is consultant physician and a pathologist, and she is head of department in Rashid Hospital, Dubai. And she will be speaking to us about clinical evidence and outcomes of CGM use. Dr. Khadija, welcome to our webinar, and floor is yours.
Assalamu alaikum, dear colleagues. Good evening, everyone. It's a great pleasure for me to be with you tonight, and it's an honor to actually be the first in the series of the Diabetes Educators Voice, and so it's a really great pleasure for me to be here tonight, and just doing the technical thing of sharing my slides. So what I'm going to try and do is really set the scene around how we can improve clinical outcomes for people with diabetes using continuous glucose monitoring. As you've heard, we're going to have 3 talks, and I will just sort of do the introduction, and then you're going to hear a little bit more about the practicalities, and then about the Dexcom Academy as well, since they're our great sponsors for tonight. So before I do that, these are my disclosures, and I will just touch upon, the basic technology around continuous glucose monitoring, look at the clinical evidence, the hard clinical evidence on the benefits, and how we can use this data to make the lives of our patients better. Now, we all aim at getting better glycemic control for our patients, and in the sort of pursuit of improving the hemoglobin A1C, we want to do that in a way such that we don't have hypoglycemia, and we limit the glycemic variability as well. So it's this sort of triangle that we all try to perfect. But many of our patients have difficulty, and it's not just in my clinic, but I'm sure in your clinics as well. We have a lot of patients who struggle to do this. And the reason for that is because we know that there's more than 42 factors that affect the glucose levels, starting, of course, from what we put in our mouths, the medication that the individual might be on, the kind of activity that they may be engaged in. There's biological factors as well, stress, illness, insufficient sleep, and so on. And then there's the environmental factors as well. Sometimes just as change in the altitude may actually also impact the glucose levels. And so we can appreciate, therefore, then how difficult it is, to get patients to perfect glucose control all the time. Now, most of you will be aware of the glucose monitoring diary. I'm sure there's still probably patients who come to the clinic, as part of their homework. They've listened to their physician, to their educator, and they come in with their report cards, as it were, and they've, spent a lot of time sort of scribbling and filling in the numbers. It is a crude way of monitoring, because it doesn't really give us any averages. There's lots of limitations. You don't have any information on the glycemic variability, and you don't have any trend or record of the hypoglycemia frequency. And so in this day and age, which kind of tool would you prefer? The traditional sort of glucose diary? Should we rely primarily just on the hemoglobin A1C? And we'll talk about the pitfalls of that tool. Or would you rather, have your patient have something more dynamic that they can sort of use, relate to, and make sort of day-to-day changes themselves rather than waiting for their appointment, which is sometimes in 3 or 6 months, and the event has already passed, and they've succumbed to the burden of hyperglycemia or hypoglycemia. So some sort of just basic differences between the finger sticks and the continuous glucose monitoring. As you know, the finger stick measures mainly the capillary blood glucose. It provides more sporadic data because the patient cannot be checking their sugar with a finger stick 24 hours. It only provides us with a snapshot, and it can be terribly burdensome for people living with diabetes. The CGM, on the other hand, measures this interstitial glucose, and I think it's very important to tell that to the patients as well, because sometimes when they see that lag or differences, they kind of get very confused and think, oh, this is not accurate, it's not, and therefore they may get put off by that. It, of course, provides real-time glucose data, and it provides us with insights into glucose patterns that can be used to either preemptively correct for hyper or hypoglycemia using the arrow trends, as we're going to see in the next presentation. So what other information can we get from the CGM devices? And the seminal paper in Diabetes Care 2019 by Battaglino introduced us to the concept of time in range, which is the percentage of time that we would like the patient to be in their target range. So usually, and this is depicted very simply in a traffic light system, whereby the green should be the most, so greater than 70% for most individuals. We want less of the yellow, which is hyperglycemia, and we definitely do not want to see them in the red zone, which is hypoglycemia. The other sort of metric that the devices give us is the glucose management indicator, which is the CGM derived estimate of the hemoglobin A1C. And so what we would like to see in a 24-hour period is at least 17 hours of the green, so being in time in range, less than 6 hours in the yellow zone, and definitely less than an hour in the red zone. But we also have, and so here is an example of the sort of ambulatory glucose profile report of a patient who is doing extremely well. Their target range is about 85%. And this is an example of a patient who's not doing very well because his target range is only 47%. And there are other things that we need to look into, but I'm not going to talk too much about those because those will be discussed by the subsequent speakers. Now, there's also an international consensus with regards to the targets. So for individuals with both type 1 and type 2 diabetes, we would like them to have a target range that's above 70%. For older individuals or for frail elderly, that split can be a slightly lower, even at a time in range of about 50% can be acceptable. During pregnancy, for type 1 diabetes, we also would prefer for them to have a time in range that is greater than 70. And in fact, for gestational and type 2 diabetes, we want to see almost 90% in order to avoid some of the complications that are associated with diabetes during pregnancy. And then what is the significance then of this time in range? It does really complement the hemoglobin A1C. We don't usually consider it as in replacement of the hemoglobin A1C, but rather as a complementary metric. It can predict the risk of complications, but what is really important is that we use what it demonstrates is that for the same level of hemoglobin A1C, you will find that the patient has a different time in range pattern. So this is where the hemoglobin A1C sometimes can be quite deceiving, because remember, the hemoglobin A1C is really an average of what the glucose excursions have been over over time. So here are 3 patients that have all got a hemoglobin A1C of 7%, and you might be thinking, oh, that's great if you just look at the hemoglobin A1C. But then when you dig further and look at what is actually happening, you will see that this individual is actually on a roller coaster, is either high or low, and though it sort of then averages out as a mean blood glucose of 154, and then you get the 7%. But this glycemic variability is huge for this individual. The second one in the middle, same thing, averages off to 154, but you can see that again that there's a huge variability, slightly better than the first individual, but still impact the complications, particularly the microvascular complications and even the macrovascular complications. Whereas this is more ideal, where you've got patients in time in range for 100% of the time. Of course, the mean glucose is about 154 milligrams and giving you the A1C of about 7%. So here again, it shows us that using the HbA1c by itself, yes, is an indicator, and we've been using this for both epidemiological studies. However, we really need to be thinking now how to complement it with more accurate sort of estimation of what the glucose is like. So in 2022, when the American Diabetes Association and the American Association of Clinical Endocrinologists put out their recommendations, they strongly recommended it for all adults that are on multiple daily insulin injection, irrespective of whether they have type 1 or type 2. And therefore, it was considered and recommended for adults on basal insulin, those who are having problematic hypoglycemia, in children and adolescents with type 1, pregnant women, either type 1 or type 2 on intensive insulin therapy, and gestational diabetes on insulin. At the time, they said maybe recommended for GDM that's not on insulin, or type 2 on less intensive insulin therapy. However, now in 2026, the recommendations are more stronger. The recommendation is that we should be considering using CGM at the diagnosis of diabetes. It should be offered to all young adults and, of course, children. It's also recommended in people who are going to start with glucose lowering medications, be it even oral agents. And then, of course, it may be considered in individuals who are very high risk for hypoglycemia. And it may also be recommended as early initiation for those individuals who are going to be using the automated insulin delivery systems, because it complements very well with those systems, creating the sort of closed loop system. So, but then what are the evidence that these devices actually help to improve the clinical outcomes of patients with diabetes, irrespective of whether they have type 1 or type 2 diabetes? So let's look first at individuals with type 1 diabetes, and we know that there are a number of studies that have shown clinical efficacy of CGM regardless of the insulin delivery method. So whether the patient is using MDI or whether they're on insulin pumps, when it's complemented with a CGM, they have better outcomes. We know that there's significant reduction in both hospitalization for acute events, either hypoglycemia or DKA, and that relates to less absenteeism. So a child is not missing school, the individual is not missing work as a result of their diabetes. The greatest benefit, I think, is in reducing the diabetes stress that is associated with the cumbersome intrusive finger sticks. And the other thing is that we also see that there's better engagement in their own care when they can actually relate the numbers with what they're eating and the medications that they're on. And here's a meta-analysis that describes exactly what I was saying. So in individuals, this is a meta-analysis showing the improvement in time in range using the CGM. And as you can see, the forest plot right here, it's favoring CGM. You have the improvement in time in range when CGM is utilized. Now, the HypoD study was a study that was done in individuals with type 1 diabetes who had impaired hypoglycemic awareness or severe hypoglycemia. And what the study did was to include around 150 participants that were on multiple daily injections for 6 months. And it was a multi-center study that was conducted in about 12 diabetes centers in Germany. And they randomized these individuals for either to get the CGM or to use the traditional finger sticks. They did have a run-in period where they had 4 weeks of blinded CGM, and then they were randomly assigned to either have the CGM or SMPG. And what it showed very clearly is the individuals that were on the CGM had much less number of hypoglycemic episodes during the 28-day period. And the median time that was spent in hypoglycemia was also much less in those that were randomized to receive the CGM. And then another study, and this was the gold and silver study, and it's, the sustained intensive treatment and long-term effect of A1C reduction. Again, in individuals with type 1 diabetes treated with MDI, and this was quite an elegant study where the patients acted as their own controls. So in the first treatment phase, they were assigned to receive they were randomized to receive either CGM or SMPG, and then there was a washout period, and then they crossed over. So you can see that the individuals that were on the CGM then went on to SMPG and vice versa. And again, what we saw there is that there was a significant reduction in the hemoglobin A1C in the individuals that were assigned to the CGM. So that study also showed that there was long-term improvement in glucose control, because when we looked at the time in range was improved quite significantly. And you can see there, whereas the time below range and achievement of control also, again, was much better, so less hypoglycemia in the CGM group versus the ones that were on the traditional finger sticks. Question is, what about our individuals with type 2 diabetes that are on basal insulin? And the mobile study also did exactly that. They wanted to look at the efficacy of CGM in adults with suboptimally managed type 2 diabetes that were on basal insulin in a primary care practice. So again, here you have a multi-center study that was open-labeled, approximately 175 adults. And the primary endpoint was to look at the hemoglobin A1C after 8 months, with secondary endpoints looking at both the time in range, the time above range, and hypoglycemic events. And again, what it showed very clearly, and you can see from the different Kaplan-Meier curves, is that those individuals who were on the CGM had better outcomes. They had a better hemoglobin A1C levels at the end of the study, and they had better time in range compared to the individuals that were doing the traditional finger sticks. Now, again, here, this is showing you in the sort of traffic light system that there was this incremental increase in the time in range, a rapid improvement in glycemic outcomes over time. Now, what was interesting about the follow-up study is that when the study ended, they then sort of randomized these individuals. So either the 6-month extension, they stayed on the CGM, or they discontinued and then switched back to the traditional finger stick method. And what it showed is that those individuals who went back to the finger sticks actually lost the effects of the good glycemic control that they had earlier. So there was no change in treatment. all that had changed was the method in which they were monitoring their glucose, whereas in the individuals who stayed on their CGM actually, maintained their glucose control. And I've seen this quite a number of times in clinical practice, where just the introduction of the CGM without actually changing anything in the patient's medication leads to a significant reduction in the glucose profile, and then even in the hemoglobin A1C. And then as soon as the patient doesn't have that monitoring system, you see very clearly when they're not actually monitoring as closely as you can, when you have the CGM, their glucose levels start creeping up again. The other question is, does better time in range actually translate to improvement in cardiovascular outcomes? And that's very important in this era of thinking about cardiometabolic health, because at the end of the day, it's not just reducing glycemia and to prevent, DKA and so on, but we also want to see whether we can impact cardiovascular disease. And so there were two studies that were reported by Ramzi Arjan. And the first study looked at more than 200 individuals who had a recent acute coronary syndrome. And what it showed, that just 2 days of CGM showed this association between the MAGE, which is the amplitude of glycemic excursions, and major cardiac events at around 12 months, independent of what the hemoglobin A1C was. And another study, which had more than 300 patients, in patients with an acute coronary syndrome, also showed that MACE occurred in about 27% of the patients over the duration of the study period, when in those individuals who had this greater sort of glycemic variability. So again, the standard deviation of glucose can be the strongest glycemic metric to produce MACE, and can be an independent risk factor even after we've adjusted for hypoglycemia. So we would only be able to get these metrics by using CGM. Of course, we know about the benefits during Ramadan as well, for in individuals to have a safe fasting experience. We usually recommend, if they're not using the CGM during the normal days, then at least during Ramadan they should do that to avoid sort of these glycemic excursions and avoid hypoglycemia. Right, so the value of CGM for both groups of type 1 and type 2 is to discover previously unknown hypo and hypoglycemic events. We can look at glycemic variability, time spent in range, above range, and below range. We can provide actionable information derived from the CGM report. We can analyze the effects on glucose on targeted pharmacological interventions. So, how do you adjust your insulin dose and so on? And then we can also evaluate the effect of both exercise and behavior based on the real-time glycemic values. And for diet, it's so important, because then patients can actually see for themselves what that slice of pizza does to their glucose levels, and they can then make the adjustment. So if somebody does want to have that banana, maybe not the full banana, the half banana may be sufficient. Exercise as well, real-time readings can also highlight the impact of the glucose, of the exercise on their glucose levels, and encourage them to take more exercise. So the mechanism of interrupting this therapeutic inertia the CGM really acts by allowing us to make those real-time decisions. The patient doesn't have to sit down, write down their glucose readings, and then wait for 3 months to come and see their physician or come and see the educator to make a change. Doing that actually delays intensification. It encourages the therapeutic inertia. Whereas if you have CGM, you're more likely, when we educate the patients, they can make those day-to-day changes by themselves. Now, how do we ensure success with CGM? First of all, it's really important to review the patient's situation. Not all patients can actually handle so much data, but with counseling and education, I think most patients can actually do pretty well. So engagement, asking what improvements they would like to see, explaining about, the different metrics, and then discussing any sort of potential problems and how to make the adjustments is really, really crucial. There are, of course, challenges that the patients may face in terms of cost and coverage, what insurance plan they have. Sometimes there's psychological resistance. I don't want something sitting on my arm or on my belly all the time. And then, is it going to stay on? Is it going to fall off and things like that? But those are all things that can be taken care of. Then there's provider challenges as well. Sometimes if your electronic health record system is not integrated well enough with the CGM devices, it means that you have to have separate platforms to actually view the data, and that can be quite time consuming as well. Of course, there has to be sufficient training for the staff who are, engaged with these patients, so that they can counsel them on how to insert the device and how to interpret the data and what to do. And that also takes in a bit of time, but that I think is a very good use of a very rewarding for us as healthcare providers, because we see the immediate benefits on the patients. Right. So what about ensuring the quality of the device? There's so many out there. How do you select? And 4 sort of factors come into play: accuracy and reliability. How close does the CGM reading come to a true blood glucose value? This is usually referred to as the mean absolute relative difference, or MARD. Is there clinical validation or reliable user feedback? And does the device require fingerstick calibration like some older models used to have? So you will hear more about the MARD, but what to remember is that less than 10% is usually widely acknowledged as the accepted safety threshold. So here's my simple checklist. I look at the device accuracy. What is the warm-up time? What is the wear time per sensor? Does it have features of alerts and alarms for both high and low glucose levels? Does it have the capacity to share the data on smartphones and, compatibility? Does it integrate with the pumps? What is the cost? What is the local availability and support? The comfort size of the sensor, how adhesive it is, the risk for falling off, for hypersensitivity reactions. And most importantly, there needs to be training and support available. The patients need to know and have this sort of 24-hour help, a helpline available for them whenever they need to troubleshoot. So the three steps to CGM interpretation, very simply, is first to ask, is there enough data to be analyzed? So where do we look for that? You look at the percentage time that the CGM is active, then look at the problem. Is it that the patient has mainly hypoglycemia? Is it hyperglycemia, or is it both? And then where is the problem? Look at the ambulatory glucose profile, because then it gives you the time of day of fasting and all the postprandial readings as well. And then how can you adjust the therapy? Of course, by looking at the daily glucose patterns in order to make the suggestions. So as we said before starting, the AGP report will actually give you the percentage time that the CGM is active. And then it will also give you in the traffic light system where the percentage that the patient is, time in range, time above range, and time below range. Where is the problem? These daily sort of glucose profiles are so important. And then what we want to do is always address hypoglycemia first, and then you can address hyperglycemia. How do you adjust therapy? Now you want to put the whole picture sort of together and look at the trends in the daily sort of glucose patterns. And this has to be discussed with the patient. So the patient must be seeing this information as well. And then you can make the adjustments after you've addressed those daily patterns. So just to sort of summarize the impact of continuous glucose monitoring, and you'll hear more on the practical cases with the coming presentations, is that it offers better control and better quality of life for our patients. It helps with patient engagement, so patients are more engaged with their care, and behavior-driven cardiometabolic improvement, as we've seen with some of the studies that I highlighted earlier. So the scientific picture supports CGM as a powerful tool for clinical outcomes. With that, I'd like to thank you for your attention, and I think the road ahead for our patients is looking quite bright. And I'll pass it back on to our chair. Thank you.
Thank you, Dr. Khadija, for the fantastic talk. You highlighted nicely how does the evidence improve the healthcare outcomes of patients with diabetes and reducing clinical inertia. Thank you so much for your talk. I think that we received some of questions, but I will keep them till the end of the webinar, and we will discuss them all together. The second talk will be delivered by myself. I am Zainab Al-Abadla, diabetes education practitioner working at Al Jalila Children's Specialty Hospital, and I am the chairperson of Diabetes Educator Society. Let me share my slides. So my talk today will be about not all CGM data are created equal. I will explore a very important question. If not all CGM data created equally, then how can we select the right CGM for our patients? In fact, we depend a lot on numbers when it comes to our clinical decision. So what if those numbers are wrong? My talk will be a bit interactive, so I will be sharing with you every now and then a poll question, and I would love to hear your thoughts about what I'm going to talk about. This session is sponsored by Dexcom, and in my talk today, I'll cover those 4 questions. Is all CGM data safe for dosing? Can I rely on every CGM available in the market? How should we select the right CGM? What's new about Dexcom? Let me start by Amal. She is 32 years old, diagnosed with type 1 diabetes since adolescent. She is teacher, having irregular meals and waking up very early in the morning. She is managing her diabetes with multiple daily insulin injection, and her diabetes is poorly controlled with A1C 9.2. In her last visit to us, we suggested for her to start using CGM. She answered us in a very frustration state. She said that I have used CGM before. I got it over the counter. It was affordable with low price. However, it gives me a nightmare. It tells me 95 when it's low. And sometimes when I correct hyperglycemia, I crash. In fact, I don't trust those devices and I don't want to use them again. It's waste of time. Why such case concerning us? Because the use of CGM is on the rise, from 6% in 2011 to 38% in 2018. And if you will look across the age groups, the increase is seen in everyone. So nowadays, CGM is no longer just a growing number. It has become a standard of care, especially in type 1 diabetes, as Dr. Khadija mentioned. And now we are talking about millions of patients worldwide who are using CGM, with increasing use in type 2 diabetes even. So this should concern us if not all CGM data created equal. So my question to you, Is all CGM data safe for medical decision making? From your point of view, I want to know the answer. Maybe you can share the full screen with the, yes. Kindly select the most answer suitable for you. So I'll give you 20 seconds for that. Amazing. So 46% of you said it depends on the device. In fact, if the answer is yes, I'm done here. But since it depends on the device, so we need to talk. There is no doubt that the emergence of continuous glucose monitoring systems in 1999 has transformed diabetes care standards significantly, from finger stick to curves, from snapshots to pattern and AGP, and from A1C to time in range. And although we had this huge transformation in the standards of care, we navigate through an era defined by rapid technological advancement. How many CGMs are available globally today? Many. But how many of those meet strict regulatory accuracy standards? And here comes the second poll question. Do you know how many of those CGM I just showed you meet strict regulatory accuracy standards? I'll give you another 20 seconds to answer this question. So 45% said 3 only, 12% said 1 only, and 18% said all of them and those concerning me, and 13 said none of them, and again, this is a concern. In fact, out of all those devices, and sadly, I would say that not all devices listed here meets the accuracy standard criteria. Out of those, the 45% of you were correct. Only 3 devices meet strict regulatory accuracy standards. So yes, we are navigating through an era defined by revolution in the CGM landscape, but with limitation. And what does this demonstrate? It demonstrates how difficult it is to achieve those strict accuracy standards. So before sharing with you what those standards are, let us look back to history, to the evolution of the CGM. In 1999, the first CGM emerged in the market, and it was a professional CGM with only 3 days wear time. And then the scientists worked more on CGM and improved CGM. In 2006, we had the real-time CGM, and it was 7 days wear time with Bittermard. And in 2018, 20 years later, the IDF came with regulatory standards to clear the CGM. So it took from the scientists 20 years to come up with those standards, which I will be sharing with you tonight. So the iCGM, or those standards, are not just another label. They are a result of years of improvement in accuracy, safety, and reliability of the CGM. So before you rely on the CGM for your patient, you need to ask yourself those 3 questions. Is it adjunctive or non-adjunctive CGM? Does this CGM meet the iCGM standards? Does this CGM backed with a robust clinical trials? Those are the criteria I am talking about. Let me walk you through each one of them and break them down for you. Starting with adjunctive and non-adjunctive CGM. These standards will answer the question, can the device replace finger stick for insulin dosing? If your device is adjunctive CGM, means it cannot replace the CGM for the finger stick for dosing. You must confirm with finger stick before making any treatment decision. It's not approved to replace blood glucose meters. However, if it is non-adjunctive CGM, means it's a standalone CGM, It is approved for dosing, and it can replace the finger stick monitoring for dosing decision. And it approves high accuracy standards which met for insulin dose adjustment. So if the CGM cannot replace finger sticks, what does that tell us about accuracy? It tells us that the regulation doesn't test enough for treat conditions. And how would I know whether my device is adjunctive CGM or non-adjunctive CGM? Read the label. It is clearly written in the label that the measurements should not be used to make treatment adjustment, but rather as a reminder when finger break is needed for dosing. In the non-adjunctive CGM, in the standalone CGMs like Freestyle Libre and Dexcom, it's written in their label, it is designed to replace finger stick blood glucose testing for treatment decision. The second standard is the integrated CGM. In some guidelines and papers, you might read it as intro. What does this standards tell us? It tells if the continuous glucose monitoring system is designed to connect safely and reliably with other compatible smart devices and medical devices, including automated insulin delivery systems and smartphones. Is this standards important? Yes, of course. Most of our patients depend on their smartphone for monitoring. Rarely you find patient using reader or receiver. And if there is an interruption in the data, or if there is a lag, or if there is a gap in the data, or if there is delay in receiving those data, if it does not integrate strictly, it will affect the medical decision because many of our patients depends on those data for dosing, isn't it? And it is much more harm if it doesn't connect to the automated insulin delivery system safely and accurately, because the automated insulin delivery systems, the insulin pumps will depend highly on those numbers to deliver the insulin dose for the patient. So if it doesn't integrate strictly and safely with those devices, it might cause a huge harm to the patient. So how many regulatories do we have to approve those CGMs? How many regulatories are clearing and approving the use of CGM? We have two regulatory pathways. We have USA, the Food and Drug Administration, and we have the European, the CE mark guidelines or protocol. The CE mark approval, it's just approve the CGM if the CGM met general safety only. So if this CGM doesn't cause harm, in fact, they approve it as if they are approving a blood pressure machine or a thermometer. So if the CGM doesn't cause harm, then they approve it. There is no CGM specific performance threshold. There has no defined accuracy and performance metric. It doesn't guarantee that CGM device has been adequately assessed for accuracy, reliability, and safety. So the other regulatory, which is the FDA, and this regulatory is the regulatory who produced and initiates the iCGM standards. They look into the performance-focused criteria. They have a defined accuracy threshold across all glucose ranges. They have mandatory that those accuracy should present in pediatric population also and throughout the sensor life performance. They have strict data availability requirements, and they have strict defined performance controls. So in summary, the CE mark process primarily checks the general safety of the device. However, the FDA iCGM standard pathway strictly enforce strict accuracy standards, define specific performance metric for all glucose ranges. What are those standards I'm talking about? This slide clearly presents those standards. And the condition applies to those standards as and condition, not all. So for any CGM to be cleared as FDA iCGM, they should meet all those criteria. Is that easy? In fact, no. That's why not all CGMs are iCGMs. So for the CGM to meet those standards, they should prove accuracy across all glucose ranges, across dynamic changes, in lows and highs, in normal blood glucose, and even when it is changing very quickly. And in fact, if you will look to the right side of my slide here, those devices, those CGMs, to get that cleared from FDA, they need to maintain a critical safety gates. If they don't maintain those gates, means they are out. What are those gates? When it comes to the dangerous error, FDA standards tolerate 0% of those errors. What do I mean by that? It gives you low when it's high, or it gives you high when it's low. And this is very important because if it shows low and the patient did not treat hypoglycemia in a proper time, this might lead to a dangerous consequences. And if it's high and the patient did not know that it's high, this might lead to DKA. The second safety gate is rate of change. And I mean by that the trend arrows. They accept less than 1% rate of change. Why? Because it can't tell the patient it's falling while it's raising, because patients depends on those trend arrows in their dose adjustment. And the last safety gate is they have additional mandate that all those accuracy ranges should be performed equally in pediatrics. And you know how much it is, the blood glucose or the glycemic metrics are variable in pediatrics. So it's even harder to achieve those rates and those metrics in pediatric population. So here comes the third question. Would you prescribe an adjunctive non-iCGM for a patient who complained of recurrent severe hypoglycemia? I'll give you another 20 seconds to answer this question. Okay, some of you said 28% said yes, they would. So let me proceed and share with you the selection criteria. You might change your mind. When it comes to whether the CGM is backed with robust clinical trials, I think Dr. Khadija explained very well and shared with you all the evidence which shows that the CGM improved the healthcare outcomes of the patient by lowering the A1C, reducing hypoglycemia, and improving time in range. So what was wrong with AML? Was it the CGM is not working, or is it the selection of the CGM? When you select a CGM for your patient, it should be backed with robust peer-reviewed clinical trials. It should represent, it should be representative across target population and throughout full sensor wear period. It should be proven of accuracy across dynamic changes, significantly including critical hypoglycemia. It should be iCGM FDA regulation meets, because this will tell you whether this device or CGM integrated accurately and safety with the smartphones or medical devices. So I put those criteria I have shared with you just now, and the guidelines shared by Dr. Khadija in her previous presentation, and I came up with a systematic 10 points check for personalized device selection. So when you select a device for your patient, it's a 10-point checklist. You just need to tick those checklists and make sure that you are choosing the right CGM for your patient. So when it comes to the clinical safety, it should be non-adjunctive CGM. It should meet the iCGM criteria. It should be accurate during hypo, and it should be tested for a special population like pediatric, pregnancy, and patients with renal diseases. When it comes to the digital ecosystem, does it integrate right with the smartphones? Does it perform the cybersecurity? Does it create a data gap, or we will have a full picture without any delay as in the AGP report? Does it can you monitor it remotely or not? The third is the most important, which is the patient fit. And I can say here that there is no one size fits all. So you need to choose based on many factors related to the patient. First of all is the usability feature, the wear time, the warm up speed, and the alarm customization. Second is access and cost. Can the patient afford it? Is it covered by insurance? Because continuity of care when it comes to the CGM is very important. Lifestyle match, we are talking here about the language, the support, the daily routine of the patient, and the technology comfortable level. So as Dr. Khadija said, that those patients need to have a structural education to use those devices, because we are trying to get the best out of the system. So if it is supported by education, patient will find it easy and will use it in more optimized way. Coming back to Amal, what went wrong with her? Her selection was improper. She used adjunctive low-cost CGM. This CGM leads to a dangerous misdosing risks and high user frustration. So this slide brings me back to the title of my talk today. Not all CGMs are created equally. If you will choose a low-cost, non-standard CGM, you will have inaccurate laws, you will have poor security and limited integration. But if your CGM was an FDA-cleared iCGM, you will have more accurate data, safe for dosing, and robust connectivity. So what is the lesson we learned from Amal case? Regulatory standards plus clinical personalization will optimize patient safety and health outcomes. For Amal, we introduced Dexcom G7 for her, and she visited our clinic in 3 months time, and her A1C improved to 7.4, and she showed more satisfaction, and she was more confident in dose adjustment and calculation based on those CGM data. So technology doesn't save the patient. However, accurate technology does. Since we started at Dexcom for Amal, let us know, or let me share with you what's new about Dexcom G7. Dexcom G7 is all-in-one device, and it's 60% smaller in size than G6. It has a rapid warm-up time, 30 minutes, and the warm-up time starts from the insertion time, not from the pairing time. So if, for example, the patient inserted the sensor and start downloading the application, or inserted the sensor and then took off the old sensor, the time counts from the insertion minute. So after the patient finished the insertion or finished downloading the app, if he took like 15 minutes in the inserting the app or taking off the old sensor, the only will left for warm up and for the sensor to be active is 15 minutes. So 30 minutes, total of 30 minutes from the insertion time, not from the pairing time. Extended wear time. So since Dexcom now extended to this to 10 days plus 12 hours grace period. So prior to the sensor end time or expiration, it will give the patient another 12 hours to change the sensor. Insertion site, it's the most wear location, and it is the only waterproof CGM. And waterproof is different than water resistance. So it's waterproof to 24 hours, and we can apply it to the back of the arm, in the abdomen, and in the upper buttocks for kids from 6 years old, 2 to 6 years old. It is safely integrated with the automated insulin delivery system, like what we use now extensively is Omnipod 5, and it is directed to Apple Watch and Apple iPads. And this is very important to any pediatrician, because we don't usually, diabetes and diabetes consumables and diabetes cost by itself is a burden. So instead of asking them to buy a phone for their kids so they can connect and follow the child. If the child has Apple iPad, the Dexcom connected nicely with the Apple iPad. It's real-time sharing, no need for scanning, and this improve there is no gap in the data and there is no interruption in the data. The CGM standards in 2026 is that Dexcom G7 wear time increased to 15.5 with a grace period, so 15 wear days and 15 hours of grace period, and the MARD improved to 8% for adults above 18 years old. I wanted really to highlight the amazing alert features of Dexcom CGM. Dexcom CGM has two important, and the first one is the low soon alerts, where the system will alert the patient or warn the patient when the glucose is expected to be at or below 55 within the coming 20 minutes. And this is very important for the patients who has hypoglycemia and awareness. It will alert them even before the hypoglycemia from occurring, and this is very important to prevent severe hypoglycemia. Not only that, it's important to prevent the rebound hyperglycemia after severe hypoglycemia. The second alert, and this is new to Dexcom G7, which is delay first alert. And it is a customized alert where the patients can delay the first high alert after his meal, for example. So let us assume that I have a child who is just finished his break and entered to his class. Logically, his blood glucose will raise after he eats. However, we allow 2 hours time for insulin to work, and we will evaluate whether he needs correction or not 2 to 4 hours after the meal. So instead of, because he just ate and he knows that his blood glucose will shoot up, so instead of keeping the device beeping, telling him that you are hyperglycemic, many kids will feel impressed from that. Some people, if they have meeting, for example, they don't want during the meeting after their lunch for the phone to keep on beeping. So they will delay the first high alert. So how we will put it on? So you will delay the first alert, and what is your hyperglycemia level? So for example, if it is more than 180 or more than 200, I don't want an alert for you have from 15 minutes to 4 hours. So this will reduce the alarm fatigue of the patients. So coming to integration, I would say that Dexcom is the best CGM to integrate with Omnipod 5. From my experience and from evidence. Why is that? First of all, it increased the time and range up to 15.6% for pediatrics and 9.3% for adult. And it reduced A1C 0.7 for pediatric and 0.3 for adult. But why it's unique and it's the best from my point of view? First of all, it's real-time CGM. So there is no interruption of the data. There is no scanning needed. So this will give the more time in hybrid closed loop. However, if with other devices, if the data got interrupted, you need to keep on scanning to get those data. Second is share and follow. And since I am a pediatric educator, it's very important for parents to follow up their kids, and they will not agree to disconnect from their kids. So Dexcom will allow to connect to the PDM, which is personal diabetes manager, and with the child phones, and with his parents, and with the Apple Watch. So it's full system of integration. However, with other devices, if the CGM is connected to the pod, the follow-up will be declined. So parents cannot monitor their child, and the child cannot share the data with their parents. Even the platform where the data, the cloud where the data is collected will be declined as well. And it is the only waterproof system. Why? Because Omnipod is a waterproof system and Dexcom is a waterproof system. So it is the only waterproof AID system. Most of wear locations, and this is very important when it comes to the Omnipod 5, because Omnipod 5 need to align with the sensor. And later on in the coming series, we'll have a session about Omnipod 5, and we will explain to you why alignment is necessary. So since Dexcom can be inserted in different location, this will give us more flexibility in aligning the pump with the sensor. And as I said, it connects nicely to the smartwatch. So in summarization, this is how it works. So the sensor will be connected to the pod will be connected to the PDM, the sensor will be connected to the mobile and to the smartwatch, and the mobile will be connected to the parents. So it's full integration system with optimizing the connectivity. My takeaway messages: not all CGM data are created equal for clinical outcomes and patient safety. So if you want to risk your patient safety, choose non-iCGM devices. We need to fully follow the FDA CGM standards, and you should not put your patient safety at risk. Selection must be personalized. As I said, there is no size fits all, and every CGM should meet strict benchmarks, non-adjunctive use, and robust clinical evidence. This brings me to the end of my presentation. I would invite you to scan the QR code and join us in our official society webpage, so you will be updated always with the upcoming webinars. Thank you. Okay, so I will stop sharing and I will introduce our third speaker, in fact, Ms. Alia Safi. She is joining us from Saudi Arabia. She is from Dexcom team, and she will be sharing with you Dexcom Academy. Alia, floor is yours.
Thank you so much, Mrs. Zainab. I'll be sharing my screen to share with you a very interesting topic that we are proud to present today. So my name is Alia Safi. I'm the head of marketing and PR for Middle East and Africa. I'm super excited today to present to you Dexcom Academy for UAE. So I'll walk you very quickly just to recap of what we has just mentioned by Ms. Zainab, and then I will walk you to the Dexcom Academy. So first of all, just want to give you a quick hint who we are as a Dexcom. We are a company who believes in patient care, and we would like always to empower people to take control of health. We listen, we think big, we always consider any feedback that comes from our healthcare providers or from our patients to develop our innovations. And this is how all of our innovations has come. So you will never find a hardware that has been launched into 2022. It's the same as today. It has been developed with the software accordingly. So we are available in more than 65 countries. We have more than 25 offices, and we are the most penetrated countries CGM available across the world with 4 manufacturing sites. We have 3 offices for the Middle East and Africa region that we are supporting the whole entire region from these offices, and we are existing in multiple countries. So our story started in the 1960s. We had researchers from the University of Wisconsin and Madison who had started to work on groundbreaking research to advance the diabetes management and come up with the CGMs. It took them more than 30 years to come up with the first CGM being introduced in the world in the 1999, where Dexcom was founded in San Diego, and we have introduced the first CGM to the market. From 2006 to 2024, we have introduced different 9 unique CGMs in the market. We have improved our CGMs based on the feedback that we have got from our patients and from our healthcare providers. And we have introduced the concept of ecosystems compatibility with the Follow app, the Caregiver app, and the Clarity, the HCP portal, and the AID and the connectivity to pen and the direct to watch. And nowadays, we are proud to have more than 3.5 million users across the world. And we are, as I have mentioned, we have more than 25 countries in the offices and more than 65 countries penetrated. And we are not standing over there. We always introduce the latest technologies in the market. So whenever we come with the latest technologies, we phase out the old ones and introduce the new ones. Accordingly, we want to make sure that everyone has the access everyone with people with diabetes has the access to CGMs, and we are introducing different kind of CGMs that fits the patient's needs. So not to overwhelm the patient. So like people with the AID systems and the needs for connectivity, we introduced to them the Dexcom G7. And nowadays we are proud to introduce to the UAE the Dexcom One Plus, which is a standalone CGM that wouldn't overwhelm the people who are not using the pumps. So Dexcom has started with the MARTS journey that has provided the accuracy, and started this by 2006, where it was 26%. And just remember this number, it's 2015, where we have introduced the MARD, which was less than 10%, and has stated by the guidelines that this is a device that you can take a treatment decision based on this one. And we are improving our MARDs year after year, and more to come in 2027 for sure. So this is why we are always say we are pioneering the CGM industry. We are the company who introduced the first to deliver the single-digit MARD accuracy level, the first approval to replace the finger stick in treatment decisions to support the patient's journey and the healthcare providers, the first to introduce the hypo alerts to increase the user safety and the concept of the alert system, the first approval to have a dedicated app for the caregivers to have the overview of what's happening with their patient, with their beloved ones, the first approval to send the glucose data directly to smartphones, and the first to enable users to monitor the glucose levels on the direct to watch, and definitely the first one to introduce the concept of connectivity to insulin pump. And this is how we are trying to improve day after day and deliver more. Because we have introduced so many technologies and we are innovative in so many technologies, we are committed always to improve diabetes outcomes along with the healthcare providers. Accordingly, we always has put in the middle our improving the diabetes outcomes, and we are supporting the whole ecosystem that comes around the patient. So first of all, we are supporting the healthcare providers with the education and awareness. We are supporting also the patient and public to increase the awareness around the CGMs, diabetes, and the lifestyle management. And we are supporting the healthcare accounts with multiple services and the supply of our innovations. And speaking of healthcare providers, we are very proud to provide to you and present to you our first Dexcom Academy that would comes to UAE, and this is the first time that we introduce it for a public, for a big group. So Dexcom Academy, I will just activate a video over here, and it will give you a journey of the Dexcom Academy, and then I will talk about it. So this video has showed you that we have different colors, we have different approaches, and we are personalizing the learning journey of diabetes through Dexcom Academy. So what is our objective from Dexcom Academy? The objective of Dexcom Academy is to give our healthcare providers an access to integrated education curriculum that covers the diabetes management, the latest innovation, the international updates, and also the localized outlines and guidelines that is available in the countries. It is a certification as well, so that whoever goes with Dexcom Academy and they work on and start a course, they will have a certification at the end, and they will have an online categorized catalog. And it supports them also with the conversation, the healthcare providers with their patient. There will be available materials that they can download to provide to their patient and to speak to their patient to ease up the conversation with the patients when it comes to the technologies. This is not all. This is how we have thought of it. We will go with beyond the product, and we would go with the Dexcom ecosystem and the implementation. This is how we thought of it, and accordingly, we are providing an e-learning modules. We are providing and will be providing webinars live or on demand, training and tutorials. You will find it over there. Audio files and podcasts that we have seen that would help a lot, especially if you are driving on your way to work. You can listen to one of the topics that would entice you to learn more about it. Interactive patient cases, because we know that practicality will add more to the knowledge, and definitely the Ask the Expert initiative that we are having. And this is all coupled with the updates on the international congresses, the local congresses, and we will be talking about the full ecosystem of Dexcom and also the basic knowledge and the more knowledge about diabetes management. And this is not all. It's not only an online website. It's also a mobile app friendly. We recently has launched the app that would be having the first learning platform for you, so you can navigate through your way. So it's not only you have to sit next to the laptop, you can open it through your mobile app and you can learn more about it. And this is all has been developed with 14 KOS across EMEA. Gladly, we have a representation from the Middle East, Dr. Fathiya Al-Awadi. All of you you know her. And we have Dr. Lamia Zubaydi from KSA. And those all come together in multiple meetings and advisory boards to come up with the idea of Dexcom Academy and the curriculum and the competency framework that I'm going to introduce. So through this, we have also the trusted associations that have supported us. So we have the IDF has supported us with this, the Breakthrough Diabetes Type 1 in UK. We have the ASADS, and we have launched lately just the competency framework in the ATTD, and we have multiple lectures and scientific sessions that would come next, and also we will have some in the AST. So this is how we think of the curriculum, how it's gonna go. Accordingly, with the experts, we have designed that we need to understand the HCP role first. So accordingly, we will be introducing the knowledge and introducing that based on the competency and their exposure to the technology, and then consider individualized need and preference. And this is how we come with the competency framework. So in the competency framework, we have thought that we have multiple and different levels of expertise when it comes to technology. And this means that not all the HCPs, they need to be like 100% expert in the technology. Some of them, they need just a certain amount of knowledge. Some of them, they need to go more in depth in data interpretation. And some of them would be our leaders who will have a regional responsibility to support us with delivering the technologies in the market, in the countries. So we have the aware, we have the understanding, and we have the expertise, and we have the leadership. So this is the 4 levels that we are introducing within the competency framework that has been launched and published in the ATTD. And every one of this level will have a different kind of knowledge and a different kind of exposures to curriculum. So in the aware of CGM, it would be more into understanding the CGM, understanding the basic clinical application and the critical values that's supposed to be comes with the CGM and the diabetes overall, and also with the skincare, because we have understand that the skincare is something that was super important and has been mentioned. When it comes to understanding the CGMs, we will go more into system understanding. We will get more into onboarding the patient on different kinds of systems. And it would comes with the interpretation of the data that comes from the CGM, because CGM is not only a glucose data, it shows a trend of the patient, so you can understand your patients more. When it comes to experts, here we go with more clinical cases and more complex cases and troubleshooting that would support with the more complex exposure to patient cases that happening. And when it comes to leadership, we will have our KOLs and our key leaders who would support us with delivering training programs and the strategy how to improve our Dexcom Academy. So this is how we started with this one. And definitely we have identified multiple modules. So you can enter now the Dexcom Academy and you can see the different modules that we have provided. And accordingly, this is how we say it. It is a Dexcom Academy is the diabetes learning personalized to you. Whatever your CGM experience, we have tailored the resources to boost your skills and simplify diabetes management for you and your patients. It has been built and developed by HCPs for HCPs. And please scan the QR code so you can register to Dexcom Academy and leverage the knowledge over there. And we would love also to hear your feedback about the curriculum. There's always a feedback session after you finish the curriculum, and there will be a certification that would be sent out to your email. So please scan the QR code. It's available on this link, and we are looking forward to see you over there.
Thank you so much.
Thank you, Ms.
Alia, for introducing Dexcom Academy. And I would like really to encourage every one of you to scan the QR code and navigate through the curriculum and see what kind of more data you can learn from this academy. So by now we reached to the Q&A session. We have a couple of nice questions, so I will be dividing them between myself and Dr. Khadija. Ms. Yusra is asking, considering the cost, availability, infrastructure limitation in developing countries like Yemen, which continuous glucose monitoring systems are the most visible for patients on intensive insulin delivery? I would like to take this question, Dr. Khadija.
Sure, go ahead.
Thank you. As I shared with you in my talk today, that though to depend on CGM data, it should be accurate, because if the patient, if the data were wrong, the device or those data will mislead the patient. So if the patient cannot afford iCGM or CGM, which meets high standards, accuracy standards, then the alternative way is to continue the self-monitoring blood glucose with the conventional way of monitoring the finger stick. This is more accurate, more affordable, and more safe for our patients. I'm not sure, Dr. Khadija, if you have different thoughts.
Yeah, I would second that. Given the information, the experience, and the technology behind Dexcom, and you've already heard now that they've worked hard to put in a Dexcom Academy to support learning for healthcare providers. I think that would be the go-to CGM for your patients. I mean, I think it would be a good investment for them.
Thank you.
Totally agree.
So here I have another question. I think it fits your talk, Dr. Khadija. How can we adjust CGM for time in range, time below range, time above range for patient with GDM? Because the
Right.
blood sugar target is different from the standard CGM.
So the blood glucose targets are not different from a standard CGM. We know that, as I showed you in the figures, the international consensus is that for those patients with GDM, we would like to have the time in range above 90%, right? So that's the difference, right? In normal type 1, type 2 diabetes, above 70%, we're usually okay with it. Of course, the ideal is to have somebody at 100%, but given the fact that people have different lifestyles, people have different types of medications, they eat differently, we know that anything above 70% is acceptable. But in pregnancy, because you also have the growing fetus, those standards need to be a little bit more stringent, and therefore time in range needs to be above 90%. And in so doing, it's not so much the data that you collect from the CGM, but what you're going to do after. Okay? Intensify the treatment, make sure that the patient is on the correct diet, they are engaging in some sort of physical activity, and introduction of most likely insulin early on rather than in delaying the intensification of treatment. Otherwise, there's a very, pregnancy is a short time period. And if you allow hyperglycemia, then definitely you're going to have a macrosomic infant and then problems with delivery and so on. And that's why, we say the time in range is a little bit more stringent for this group of individuals compared to anybody else.
I strongly agree with you, Dr. Khadija. Thank you so much. We have a question from Dr. Afis from UK. He is asking what measures to ensure adhesion issues or adhesive issues not responding to usual measures. Thank you, Dr. Afis, for this question. Allow me to answer this since I'm educated and I've educated the patients. So, in fact, You mentioned here if the patient did not respond to a usual measure. So let me revise with the audience who doesn't know the usual measures, what they are. Patient should choose a clean site and they should clean this site with alcohol before insertion. We advise the patient to apply something called Cavilon, which is a spray. When you spray it to the on the skin, it will dry and create a barrier between the adhesive and the skin, and this might reduce the allergic reaction from the adhesive. And if this did not work, then this is off-label, but we use it widely in our clinic and it works effectively with the pediatric population. We ask them to use the nasal spray. So the nasal spray with 0.5 cortisone, if you will apply it over the skin before inserting the sensor and allow it to dry, the cortisone in the spray will prevent the allergic reaction in the site of the insertion. And if you are talking about fall off rate, so we advise the patients to use adhesive, like extra adhesive over the sensor, and there are customized one to apply them over the sensor to prevent the sensor from falling off. Another question for you, Dr. Rahila, Dr. Khadija. They are asking, can we have a specific CGM for a special patient according to their different target blood glucose sugar?
So again, when you're selecting the CGM, we've gone through the criteria. Accuracy is really important. Applicability in terms of the cost and coverage, and the lifestyle of the patient is also very important. Now, you've already heard with Dexcom, it ticks all the boxes. So this is the one that I would personally, select for your patient. And remember, whatever that you have at hand, the one that works is the one the patient can use over a long time. It's just like with the medication. It only works when the patient takes the insulin. The blood pressure comes down only if the patient is on an antihypertensive therapy. So if it's a question of cost, then use that which is affordable for the patient. But if that's not an issue, then go for the one that gives you, the best outcome for your money. And I think Dexcom, as we've already heard, ticks all these, boxes in terms of accuracy, in terms of integration with other systems. So if the patient is on an automated insulin delivery device, if they're on MDI, sharing the integration with other members of the family, for instance. In the case of children, not having to have a mobile phone, it pairs up with their tablet devices when they're in school. And then all those other alarm features that have recently been introduced are advantages, practical advantages that the patients can use to actually make life better. Because remember, what we intend to do by giving them the CGM is not just improve the glucose control, but also reduce the diabetes distress, right?
Yes.
So I hope that clears it.
Yes, absolutely. I agree. We have another question here saying that for patients care, which CGM would you recommend, especially for a patient who travels extensively and has a busy life? In fact, I will answer this question based on 3 clinically relevant points. I would recommend for such patient to use Dexcom G7. Why is that? Not because they sponsored the session today, but because Dexcom is a real-time CGM, give a hands-free experience for the patient. So the patient doesn't need to scan every now and then, and the patient will receive the data automatically every 5 minutes without scanning. Moreover, the features of the alerts Dexcom has, which is the alert, urgent low soon alert. During travel we walk a lot, and our physical activity will be higher during travel than normal days. So the urgent low soon alert will help the patient to prevent hypoglycemia. Moreover, as I explained, that the Dexcom is connected nicely with the smartwatch. So if the patient is having smartwatch, and he can check the readings every now and then, even without the need of getting his phone out and checking his blood glucose. So I would recommend Dexcom G7 for such case. We have lots of a question. I think question for Dr. Khadija here. They are asking about data interpretation. So if we apply CGM for a 64 years old female, and her fasting blood glucose showed 29 on Friday, 29 on Saturday, and 134 on Sunday, would we consider she having diabetes mellitus?
So, I mean, the question is a little bit strange, because when we do the criteria for diagnosis of, it's not age-based. The criteria, you follow the WHO or ADA criteria for the diagnosis of diabetes using either a fasting blood glucose sample, or you use the HbA1c, or you can use if the patient is symptomatic, then the random blood glucose levels as well. So we don't use the CGM data for diagnosis of diabetes, and neither is it age dependent. The criteria are the same irrespective of a person's age. So, and these readings, it's not clear whether this is a fasting reading or this is a postprandial reading. So you can't really say whether this is diabetes or not. And certainly you wouldn't say normal for age, because age's got nothing to do with it.
Thank you. A question here, I just want to highlight the answer. What are the CGM approved as adjunctive and non-adjunctive? In my presentation, clearly I shared the non-adjunctive CGM, which they are 3, Dexcom G7, Libre 2 Plus and Libre 3, or Abbott generally, and Eversense. Another question, does Dexcom G7 pair with Medtronic pumps? By the way, Medtronic changed their name to Minimed now. So no, it doesn't pair. Minimed has only their standalone CGM, which only connects with their pumps and doesn't connect to any other pump. They have Guardian Connect, and they worked on that and improved it, because the mark of Guardian Connect is very high. So now they are launching the Simplera, which will be launched in June this year. And they are launching the Instinct CGM, and it will be launched in October 26, inshallah. Is Dexcom device compatible with Android device? Yes. What are CGM devices available in King Saudi Arabia? I know that Dexcom G7 and Freestyle Libre, both of them are available. The non-adjunctive CGMs are available. When it comes to the adjunctive CGM, I am not sure, in fact. The last question we have, maybe Dr. Khadija, if you would like to take that. He is talking about, again, Dr. Afis, he is talking about the compression hypoglycemia during sleep. So sometimes the patients might see a prolonged hypoglycemia during sleep. So what's your explanation for that? And he is asking whether data Dexcom is better in this regard.
I don't think we have any head-to-head data that compares between the different CGMs, but I think it's important where you place the device. If it's on the arm, place it on an area where the patient is not going to be sleeping on it in order to compress. So there's ways to overcome that. There are some some devices, of course. The other important feature is that you've got the alarm. So if the patient does see that they've got then a sort of prolonged hypoglycemia and they know they're not symptomatic, the first thing that we say is always check with the finger stick to make sure that, is it genuine hypoglycemia or not? And then they can sort of move over onto the other side to avoid that. But I'm not aware of any sort of data that has looked head to head to say whether Dexcom is better in that regard compared to the other devices. I'm
Absolutely.
not sure about, yeah.
Yeah, absolutely. I echo your answer. And by this question, we came to the end of our webinar today. I would like you to scan the QR code and give us your feedback and stay connected so you will be updated with our upcoming webinars. Thank you so much for staying with us till the end of the webinar. And I wish every one of you a great evening. Thank you.